Marvin. Thank you for the invitation. Well, I think, well, hearing the various lectures, I felt very old this morning because many things has been said, repeated, past copy, past copy, past copy. And I think that this occasion are to rethink what you have done or what you are doing since decades. I was very pleased. I didn't agree on some of the things that Dr. Marvin was saying, but I think it's important to have sometimes, wait a second, but what are you doing? Why we continue to do the same thing without any real criticism? So what I would like to present now, not just to discuss very briefly some of the idea I have at the moment, which is the general schema that I try to use when I or judge literature or I read something, and which belongs the way the science has developed in a Western country over centuries, not in the last decades. We start with an inductive reasoning, which is I observe this, and this, and I say, well, this is in common. As an example, I look at a patient with sepsis, and I say, well, it's quite common to have some multi-organ failure. Some failure of this organ, and then of this organ, and this organ. Now, from this inductive reasoning, usually we developed a theory. As an example, in sepsis, okay, well, I observed that different organs are impaired. The theory maybe is that there is an oxygen supply dependency. Oxygen supply dependency is possibly a cause of this. Up to this point, Aristotle was already there at the time of developing a theory and developing even a deductive hypothesis. Okay, if the multi-organ failure is due to oxygen supply dependency, the hypothesis is that if I correct the oxygen supply dependency, I maybe correct the multi-organ failure. And I prove that the theory is true. Remember that the deductive hypothesis is written in the theory. And the theory is what is written in background in the abstract. 2 lines that nobody read, or very absolutely inconsistent. Then hypothesis. To here and here we stop at Descartes, Cartesio. Then start Galileo and Newton. Wait a second. I need to confirm the hypothesis, to prove the hypothesis with an experiment. Great. And experiment, prove or disprove. What prove or disprove? Just confirm the theory. Does not prove that it's right. Confirm that maybe it's right. Because it's enough one episode in which it's not confirmed that you have to go back. And from Galileo and Newton, we jump to Popper. And this is evolution of our thinking over the centuries. These then randomized trials are nothing else than a little part of this process. And I would like to look according to this schema in which each one of these may be wrong, what you are doing every day. Because the theory is the background, the deductive hypothesis is what you read as aim of the paper, then the methods are how the experiment and design, and the results prove or disprove hypothesis. Usually the people doesn't not read even this one and go to the conclusion that I did not put here, because sometimes to read all the abstract requires too much effort. But this is what we are doing every day, and what we are looking as a century of years of human thinking. Sepsis, great. Sir William Osler, except on few occasions, the patient appears to die from body response to infection than rather from heat. I'm expecting Rocky 5 just to confirm this, because Rocky 1, Rocky 2, Rocky 3, Rocky 4, more or less, did exactly the same thing, right? Because we do not cure the disease. We maintain the life with our symptomatic therapy. We maintain a decent gas exchange, a decent pressure, a decent urinary output, waiting that somebody takes care of the basic disease, which may be pneumonia, in fact, which lead to what we call sepsis, which is a human invention. But tell me, Rise, how many disagree with this? And this is a fruit, this very intelligent man looks also intelligent, which is not always the case, but developed a therapy, and then after that we have some experiment, and then we have community, individuals, literal congress, believers, not believers, all what create our belief that we sell as science. 10 experts around the table agree on the lowest common denominator. I'm terrified by the expert which provide recommendation of which nobody has any need. I not need a recommendation or some which are sometimes very fancy. But hundreds of experiments show that inflammation inhibition did not change outcome. We have milligrams, kilos of steroids. We have the most various series of blockers of the receptors, of the catecholamines, of this, of that. Tell me one that prove that blocking the inflammation changes something. So the hypothesis generated by the theory that sepsis is due to an overwhelming inflammatory response, all experiments showed that the hypothesis has not been proved. That means that the theory is wrong or is incomplete. It's very simple. So don't tell me, oh, we did it in the wrong time, with the wrong patient, not homogeneous, and blah, 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 blah. It's simply not true. That's it. Or maybe not true. It's incomplete, maybe. We have to add something. And now, if we look at this one, here is a problem. Because all experiments in different aspects show it without any doubt that hypothesis doesn't have true. That's it. And we have to accept this. Nobody died. I mean, no doctor died because we accept that we maybe were wrong for decades. And then, in the usual course running of the science, we have to go back to the theory. And now the theory is that maybe it's not an over-inflammation. Maybe in a certain time, and depending on the time, is an under respiratory immunitary response. We change completely the picture. And this requires not randomized study, my dear. Required brain, pathophysiology, and basic approach to the problems. We have a lot of players here. All these cells. All these are the same cell that we have in the cancer, that we have in many manifestations. You have to have, once we recognize that something is wrong, to sit down and to see the reality with the eyes of the baby 5 years old. Stop to read the literature. Sometimes the literature is intoxicating because it's nothing else than repetition of many. Try to use your brain and to see in the general view. Now, multi-organ failure. Irreversible, okay, forget that this was for ARDS. Is mitochondrial dysfunction? Is hypoperfusion? Is cancer-like orphan infiltration? Is fluid overload? We flooded all these poor guys. One poor man coming to the hospital and is flooded. I saw in my eyes something very... Anyway, hypoperfusion. My poor rivers say that, but the poor river, okay, maybe he patterned something wrong, but what surprised me is 49, 48 baseline SVO2 in this patient, because I'm doing this job since 40 years. Maybe I saw one patient with this. Not because River is wrong, but he was working in other part of the hospital than me, not the same hospital. But Rivers was in an emergency room. We were in intensive care. We did exactly the study of River 10 years before Rivers, and we didn't find any difference between treated and control. But maybe we have other justification. Because even if Dr. Markey ate Rivers, not ate Rivers personally, maybe yes, but he cannot hate SVO2. Because we may have whatever idea we want, but the physiology stay. And the SVO2 is a beautiful monitoring system that tells you not what the patient has, but that tells you that something may be dramatically wrong. And maybe dramatically wrong may be the oxygen saturation, or maybe the oxygen consumption, or the cardiac output, or the hemoglobin. When this one change below some, let's see, normal values, because it's sort of the needle, which indicates, okay, this is safe, means that something of this is getting wrong. And something of this may be metabolism, may be hemodynamic, may be the transport, may be the respiratory system. So if I would be in a desert island and I need one monitor, I would prefer to have SVO2 to tell me that something wrong. Then you sit down and you say, why the SVO2 is abnormal? Not necessarily for the cardiac output. Sometimes it's not the cardiac output. Often it's the cardiac output. But it's not, what is important is this coupling. And as I told you, when we did as a target SVO2 with the supranormal values, it was another myth at the time, or we found that targeting the normal cardiac index or targeting normal SVO2 were exactly equivalent. So when you want to have 70% of SVO2, is as to say, okay, I would like to have normal cardiac index. But the man doesn't die or doesn't live only because of cardiac index. Medicine, biology is far more complex than that. And then we have these 3 studies. These 3 studies, to me, are an example of what? I don't know what you tell. Let's see. I decide that we decide together that we have to do a randomized trial testing the antipyretic effect of aspirin. Okay? So antipyretic means the aspirin decreases the temperature. So we take one group A, which is control, and one group B, which is treated. Control, I give a placebo. Treated, I give aspirin. And I look at the temperature changes. What kind of patient do you choose? The patient with normal temperature or the patient with fever? to show that. I suppose that even my friend Eric Angus would choose a patient with fever. Great. No one of this study had a patient with fever. In all the patients with SVO2 was, they start with all with SVO2 greater than 70%. When I read, I start to cry and I say to me, Luciano, it's time to get out, to buy a dog and go and read other papers and not scientific papers. Because from this, it comes out that SVO2 has been shown that doesn't change the mortality, doesn't change survival. What changed mortality? Maybe Jesus Christ. Everybody of us will die. I'm not interested at all in mortality. We should be interested in the mechanism and take care of mechanism. Mortality is a side effect, or survival is a side effect of taking care of mechanism, of understanding of what you're doing, of the medical reasoning. And this is a classical example, the 3 studies, of wrong design of experiments. Nothing else. Mitochondria. I love the matter. Wait, no, I love Marvin, but I love mitochondria too. And there is an absolute ignorance about the mitochondria and about these mysterious ROS and the mysterious radicals of oxygen, they're terrible, which are commonly used, they commonly produce in the man. But clearly, when we have too low or too high, we have some problem with the formation of this. We live because of oxygen, which is sort of garbage collection. The oxygen is nothing else than collectors of the electrons. At the end, the electrons, they have lost their energy. They don't know where to go, and they go to oxygen. You have some anaerobic animals that have other molecules that are acceptors of electron. You have 2 molecules, basically, the pyruvate, which becomes lactate, and the oxygen. And these are the 2 extremes. And this in a very interesting way to look at the problem, because also the mitochondria, they change their protein every few hours. They destroy and rebuild all the proteins of the chain. And we are this continuous movement to become extremely flexible to the insult. We continue to destroy and build at a very high energy cost. And then in intensive care is the domain who takes care of all these energy changes. And looking at the ROS, there are some mysterious things. As an example, we have this one, which is the transfer of energy, which is the acceptor of the electrons. You add just 1 molecule of a phosphate, as this is the donors of electron. The non-oxidized form without electrons is very high, and this is very high. What changed this equilibrium in the cells? If you look at what you're doing every day, and you try to look the response that whatever boy would ask you, why? Why? There is not a very clear answer on that. But you are this spectacular combination of equilibrium. And in this spectacular equilibrium comes the doctor. And Dr. Fermi didn't quote the poor boys in Africa. He was speaking about the adults. But the poor boys were given an amount equivalent to 5 or 6 liters in 1 hour and a half. You almost kill an elephant. It happens to me to see the following. Patient, I have 2 minutes, because this is terrible.
You've got 2 minutes and 19 seconds.
In 90 seconds, a patient was reading a newspaper in the bed, classified as ARDS. CT scan, 2 or 3 densities, one to the right and one to the left. Now we do the recruitment maneuver. Great. I go to take a coffee. I come back, and the patient was with the tube in. He was given 2 liters of ringer lactate in the time of my coffee. He was splitting water from the eyes, from everywhere, and before he was not. I become furious. I say, now you go to the CT scan, and you will see all white. And of course, we will use the terrible recruitment maneuver. Every thumb become black, but these 2 points, 1, 2, 3, and 4. So you create the edema, and then you do the recruitment maneuver to take care of edema. And this is exactly what's happened. And with this wrong recommendation, we risk to kill hundreds of patients. Because the people stop to reason, take the protocol as the Evangelium. More than Evangelium. Fluid overload. How many conferences have you heard about the kind of fluids? Hundreds. How many conferences you have heard about where the fluids go? How much in the vessels? How much in interstitial? You say, well, 1 to 3. Wait a second, in anesthesia, few patients, normal patient, decades ago. About 40–50% goes in the cells. We flood the cells with sodium and water. And the cell requires energy to throw out the sodium. In a period in which our problem is the energy crisis, which is the critically ill patient. And so, we have intravascular, interstitial, intracellular. And a very, very, very nice myth. When you say the albumin decrease, so what does the water? Out. And you imagine the Niagara cascade coming in interstitium, maybe in the cells. Okay, let's see, make this count. I have 5 liters intravascular compartment with osmolarity 302, because the oncotic pressure equivals to about 2 millismol of oncotic pressure. And I have in the other compartment 300. Okay? Now I take out the barrier to albumin. Whatever osmolarity is equilibrates. How much is the fluid going from one compartment to the other to reach a new equilibrium? 5 liters, 15 liters. How much? Something as 150 cc's. And this is physics. But for paste, and copy, we have this terrible thing of albumin. So I have to rethink to this basic problem that we afford every day. Because about 50% goes in extracellular, in intracellular. And the cells, even in normal man, takes hours to liberate from them. And then this to me, you speak a conference about sepsis, the last slide. New England Medicine, 214, 5 randomized trial, 3 in Europe, albios, sepsis, different, but the sepsis population, if you look materials and method, exactly the same, okay? The patients are supposed to be exactly the same. So patient with severe sepsis and septic shock. That, taking the population, no one of these studies show a difference between treated and control. So consider all the population together. Italy, 42%. France, 43%. Scandinavia, 44%. US, 32%. Great. You go in New Zealand, my God. 18%. So if you have two sepsis, don't spend time, buy a ticket, and go in Australia. I mean, and you know why? Because of this poor patient in Europe were ventilated 80, 76, 69%. Look here, in US, 14, 15. And so come the scientists and tell you the mechanical ventilation killed the patient. I saw a patient enrolled in this study in the day one, sitting at the table eating spaghetti. I don't remember if with or without tomatoes, but this was in Pittsburgh. And to me, it's difficult to compare with this, but the results coming from here. I called the editor in New England and said, what's about this? You know, who cares? Because we have the big numbers, we have the validation, we have the trialist, and we have all the story in which we lost absolutely what is the common sense. Try to think to that, okay? And I thank you for the attention.